In this video, we can discuss about pharmacology of hypolipidemic drugs. It is an important topic from pharmacology of drugs acting on cardiovascular system, which is important for different courses like MBBS, BDS, BSc nursing, B.Pharm, PharmD, etc. So in this, we will discuss the introduction, mechanism of action, classification, ADR and uses of different classes of hypolipidemic drugs. So let's start with the definition of hypolipidemic drugs. We can define hypolipidemic drugs are the drugs which will lower the level of lipid and lipoprotein in the blood. We can also define these are the drugs which are used to treat hypolipoproteinemia. Now, what is the use of hypolipidemic drugs? What is the importance? These drugs have some potential to prevent the cardiovascular diseases by retarding accelerated atherosclerosis in case of hyperlipidemic individuals. So, for the treatment of hyperlipidemic individuals, we may have to go for drug therapy to lower the plasma lipid in addition to the dietary management and the correction of some modifiable cardiovascular risk factors. Now, before jumping to the drugs, let's have an idea about different hyperlipidemic condition. What is meant by hyperlipidemia? It is also known as hyperlipoproteinemia because it is the condition of high level of fats like lipids and lipoprotein in the blood, and which is the common disorder in developed country and which are the major causes for coronary heart diseases. Now, why or how this hyperlipidemia will occur? It may be due to the abnormality in the lipid metabolism, or may be due to the plasma lipid transport abnormalities, or may be due to the disorders in the synthesis and degradation of plasma lipoproteins. Now, what are the different causes of hyperlipidemia? It may be due to the lifestyle or food habit, like the patient may be obese, or he may be not exercising, or he may be have some smoking habits. And another cause of hyperlipidemia is some treatable medical conditions like diabetes, obstructive jaundice, and some case of thyroid gland inherent hyperlipidemia. Now, what are the different type of hyperlipidemia? We can classify hyperlipidemia into 5, total of 6, including that 2 is again classified into A and B. So, first type is also known as familial lipoprotein lipase deficiency hyperlipidemia. The cause of this is genetic, and this is very rare type of hyperlipidemia, and there will be an increased chylomicron in the plasma lipoprotein, and also there will be an increased cholesterol and increased triglyceride level in case of type 1. And in case of type 2A, it is also known as familial hypercholesterolemia, and cause is genetic. These are less common, and there will be an elevated low density lipoprotein, and there will be an increased cholesterol level. There will not be any increasing triglyceride level in type 2A hyperlipidemia. Now, coming to the type 2B type of hyperlipidemia, it is also known as polygenic hypercholesterolemia. The cause is multifactorial. Different factors may affect this type of hyperlipidemia, and this is the most commonest form of hyperlipidemia. There will be an increased low density lipoprotein, and there will be an increased total cholesterol. Then coming to type 3, it is also known as familial beta lipoproteinemia. Cause is genetic. This is a rare form of hyperlipidemia. There will be an elevated low density lipoprotein and chylomicron remittent. There will be an increased cholesterol level and total glycerol in case of type 3. And coming to type 4, it is also known as hypertriglyceridemia. Causes are multifactorial as well as genetic. This is the common form of hyperlipidemia. There will be an increased very low density lipoprotein in case of type 4, and there will not be any increase in cholesterol level, but there is a increase in level of triglyceride level in case of type 4 hyperlipidemia. Now coming to type 5, it is also known as familial combined hyperlipidemia, and the cause is genetic. This is a less common form of hyperlipidemia, and there will be an increasing very low density lipoprotein and low density lipoprotein. Also there will be an increase in cholesterol and triglyceride level in type 5 hyperlipidemia. So these are the different types of hyperlipidemia. Now coming to what is the importance of treating this hyperlipidemia, because the hyperlipidemia will cause different risk factors and complications for atherosclerosis. So we can divide the risk factors into two: modifiable risk factors and non-modifiable risk factors. And the modifiable risk factors are, first one is dyslipidemia. It will cause increasing low density lipoprotein as well as increasing modifications of different blood vessels. And second risk factor, modifiable risk factor, is hypertension. It will cause increasing permeability as well as increasing intimal low density lipoprotein retention, increasing low density lipoprotein binding to smooth muscle cells also. Another modifiable risk factor is tobacco smoking. This will cause increasing LDL and endothelial dysfunction. Another modifiable risk factor is diabetic mellitus, which will cause LDL glycation as well as endothelial dysfunction. And obesity, another modifiable risk factor, which will cause increasing insulin resistant hypertension as well as dyslipidemia. Now coming to non-modifiable risk factor, it may be the age, or it may be hereditary, or it may be the jail. In case of male genders, it will leads to decreasing mediated atheroprotection and decreasing LDL and increasing HDL and increasing LDL. So all this risk factor will lead to atherosclerosis development and progression. Now what will happen if there is an atherosclerosis development and progression? It will lead to different complications like calcification, rupture, hemorrhages, embolization at distal sites, and aneurysm. So calcification may lead to different conditions like renal artery stenosis or angina or peripherally vascular diseases, and rupture may lead to different conditions like myocardial infarction and thrombotic stroke, and embolization of distal site may lead to embolic strokes, and aneurysm, which is a common form of weakness of artery and which may lead to abdominal aortic aneurysm. So these are the different factors and complications of atherosclerosis. Now, when we should start the treatment for hypolipidemic drugs? So in order to understand that, we have to know some safe level of plasma lipid in our body. So we can classify the level as optimal or desirable level, borderline or high level, high or very high level, etc. So we do not have to treat if the level is between optimal level, like if the total cholesterol less than 200 and LDL cholesterol less than 100 and HDL is greater than 400 and HDL greater in men and greater than 50. HDL is greater than 40 in case of men and 50 greater than 50 in case of women, and if total cholesterol level or total triglyceride level is less than 150. Now we can say the hyperlipidemic level or hyperlipidemia is in borderline if the total cholesterol is between 200 to 239 and LDL cholesterol is between 130 to 159 and triglyceride level is between 150 to 1999. Now we need to treat the high level of plasma lipid if it is greater than 240 total cholesterol and LDL level if it is between 160 to 189, and if the HDL level is greater than 60, and triglyceride level is 200 to 499. So above this high level we need to treat with some hypolipidemic drugs. Now coming to the classification of hypolipidemic drugs, it is mainly classified into HMG-CoA reductase inhibitors like lovastatin, simvastatin, pravastatin, atorvastatin, rosuvastatin and pitavastatin. Now second classification is bile acid sequestrant like cholestyramine and Colestipol, and third classification is lipoprotein lipase activators like clofibrat, benfibrose, Fibrozil, benzafibrate and fenofibrate, and lipolysis and triglyceride synthesis inhibitors like nicotinic acid and sterol absorption inhibitors like estimamide. So this is the classification of hypolipidemic drugs. We also have some other drugs like gugulipid and probocol which are in natural origin. Now coming to the mechanism of action and pattern of lipid lowering of different classes of drugs. First we can see the mechanism and effect of lipid by HMG-CoA reductase inhibitors like lovastatin, simvastatin, atorvastatin and rosuvastatin. They act by inhibiting the rate limiting enzyme HMG-CoA reductase enzyme, thereby it will increases the cholesterol synthesis, and it will decreases the 20 to 55% of LDL. It will increases the 50 to 150% of HDL, and it will decreases the 10 to 35% of triglyceride in our body. Now coming to the second drug, that is bile acid sequestrant like cholestyramine and Colestipol. They will act by decreasing bile acid absorption and increasing hepatic conversions of cholesterol to bile acids and increasing LDL receptor on hepatocytes to decrease the cholesterol. Now by the action of bile acid sequestrant, it will decreases 50 to 30% of LDL, and it will increases 3 to 5% of HDL, and in case of bile acid sequestrant, triglyceride level is not affected. Now coming to third class, fibric acid derivative like Gemfibrozil, benzafibrate and fenofibrate. They act by a mechanism of they increases the activity of lipoprotein lipase and also by releasing fatty acid from adipose tissue. And by the action of fibric acid derivative, it will decreases 5 to 20% of LDL, it will increases 10 to 20% of HDL, and it will decreases 20 to 50% of triglyceride level in the blood. Now coming to the nicotinic acid, it will act by a mechanism of by decreasing the production of very low density lipoprotein, and also it will act by decreasing lipolysis in adipose tissue. By the action of nicotinic acid, it will decreases 15 to 25% of LDL, and it will increases 20 to 35% of HDL, and it will decreases 20 to 50% of triglyceride level in the blood. So these are the different mechanism of action and pattern of lipid lowering drugs. Now we can go for the pharmacology of each classes of hypolipidemic drugs. We can start with the HMG-CoA reductase inhibitors. The important drugs in these groups are atorvastatin, rovastatin, simvastatin, lovastatin, pravastatin, rosuvastatin and pitavastatin. So what is the mechanism of action of HMG-CoA reductase inhibitors? As the name indicates, they will inhibit an enzyme HMG-CoA. So what is the importance of this HMG-CoA? Which is an enzyme which is responsible for the conversion of 3-hydroxy-3-methyl-glutaryl coenzyme, which is known as HMG-CoA, to mevalonate, which is an rate limiting step in the cholesterol synthesis. So by inhibiting this enzyme HMG-CoA reductase inhibit, it will inhibit the conversion of HMG-CoA into mevalonate. So this is the rate limiting step, and which is converted to farnesyl pyrophosphate and then to saccharine, and from the saccharine the cholesterol is synthesized in our body. Okay, so this is the rate limiting step, which is the conversion of HMG-CoA to mevalonate. So by inhibiting the enzyme responsible for this conversion, it will inhibit the conversion of HMG-CoA to mevalonate and thereby sequential action of the following steps, and finally it will inhibit the synthesis of cholesterol in the body. So that is the mechanism of action of HMG-CoA reductase inhibitors like statins. Now the therapeutic dose can reduce the cholesterol synthesis by 20 to 50%, and it may result in a compensatory increasing LDL receptor expression on the liver cell, and thereby it will increases the receptor mediated uptake and catabolism of LDL and intermediate density lipoproteins as well as low density lipoproteins. Now coming to the pharmacokinetics, since the HMG-CoA reductase enzyme activity is maximum at night, it is better to administer at bedtime to obtain maximum effectiveness. That's why all the statins are administered during the bedtime. But this is not necessary for the some drug like Atorvastatin and Rosuvastatin due to its long plasma half-life. So all other statins has to be administered at bedtime, and it is not necessary for Atorvastatin and Rosuvastatin for its prolonged plasma half-life. Now coming to the adverse drug reactions, the important adverse drug reactions of HMG-CoA reductase inhibitors are gastrointestinal complaints and headache, rashes and sleep disturbances, rise in serum transaminase, muscle ache and myopathy. And some other statins like lovastatins may cause, there will be an increased creatine phosphorus kinase and flatulence and nausea. Simvastatin may cause headache, nausea, flatulence, heartburn and abdominal pain. Pravastatin may cause GI disturbances, headache, insomnia, chest pain and rashes. Atorvastatin may cause headache, flatulence and diarrhea. And rovastatin may cause headache, dizziness, constipation and nausea and vomiting. So these are the important adverse drug reactions of HMG-CoA reductase inhibitors. Now coming to the drug interaction, one of the most important drug interaction is with the nicotinic acid and gemfibrozil as well as other cytochrome P450 inhibitors like ketoconazole, erythromycin, cyclosporin and protease inhibitors. So all these drugs will cause myopathy along with the HMG-CoA reductase inhibitors. One is gemfibrozil. Along with the gemfibrozil, it will inhibit the hepatic uptake of statin by organic anion transporter. But the fenofibrate will interfere the least. The hepatic uptake will be interfere with the least with fenofibrate. So this is preferred when combined with the HMG-CoA reductase inhibitors. Now coming to uses, HMG-CoA is the first choice of drug for many cases like for primary hyperlipidemia with raised low density lipoprotein and total cholesterol level with or without raised triglyceride level. So this is very useful in case of type 2B, 2A and type 5 type of hyperlipidemia. Now this is very useful for secondary hypercholesteremia due to diabetic nephropathic syndromes. So that is the uses of HMG-CoA reductase inhibitors. Now coming to the second class of drug, that is bile acid sequestrant like cholestyramine and Colestipol, and these are the basic ion exchanger resin supplied in the form of chloride form. Now what is the mechanism of action? These drugs will not digest or absorb. They will bind with the bile acid in intestine and they will interrupt their enterohepatic circulation. So this will lead to increased fecal excretion of bile, salt and cholesterol, and this indirectly will lead to enhanced hepatic metabolism of cholesterol to bile acid also. It also have some actions like it will decreases the bile acid absorption, it will increases the hepatic LDL, and it will decreases the conversion of cholesterol to bile acid, and it will increases the LDL receptor in hepatocytes. These are the mechanism of actions of cholestyramine and colestipol. Now coming to the adverse drug reaction, it may cause unpalatable and inconvenient effect, and we have to take a large dose for the effect of hypolipidemic action, and it may also cause flatulence and other GI symptoms, and it may interfere with the absorption of many drugs and have poor patient acceptability. And it is mainly used to retard the atherosclerosis, but this is not popular in clinically because of its adverse drug reactions of unpalatable as well as inconvenient use due to the large dose. So these are the uses of bile acid sequestrant like cholestyramine and colestipol. Now coming to the next class of drug, that is lipoprotein lipase activators or fibrate. The drugs include clofibrate, fenfibrate, benzafibrate and gemfibrozil. The mechanism of action, all these clofibrate and lipoprotein lipase activators will activate peroxisome proliferator activated receptor or PPAR alpha, which is that is a gene transcription regulating receptor expressed in the liver and fat. So by the activation of PPAR alpha, it will enhance the synthesis of lipoprotein lipase, which is a key enzyme in the degradation of very low density lipoprotein. So it will result in the lowering of circulating triglyceride level, and also it will cause fatty acid oxidation. So these drugs act by increasing blood HDL cholesterol and not lowering the LDL cholesterol. So that is the mechanism of action of lipoprotein lipase activators like clofibrate. Now coming to the adverse drug reaction, it may cause epigastric distress and loose motion, skin rashes, body ache, eosinophilia and impotence, and headache and blurred vision. And the important drug interaction is gemfibrozil with statins will increases the risk of myopathy, and it is contraindicated in case of pregnancy. Now coming to the uses, it is very effective in type 3 hyperlipoproteinemia, and this is the first line of drug for the patient with marked rise in triglyceride level, whether or not the cholesterol level are raised. Usually gemfibrozil 600 mg BD is taken before the meal, and it is also used for the episodes of acute pancreatitis are prevented in patients with chylomicronemia and severe hypertriglyceridemia. So these are the uses of lipoprotein lipase activators. Now coming to the lipolysis and triglyceride synthesis inhibitors like nicotinic acid. As we know, nicotinic acid is a vitamin B complex which in much higher dose will reduces the plasma lipid. So it will decreases the triglyceride as well as very low density lipoprotein very rapidly, followed by modest fall in low density lipoprotein cholesterol and total cholesterol. And this nicotinic acid is most effective drug to rise the HDL cholesterol, and probably this rise in HDL is by decreasing rate of HDL destruction. And nicotinic acid will reduces the production of very low density lipoprotein in liver by inhibiting triglyceride synthesis. Now coming to the adverse drug reaction, it may cause marked flushing and heat and itching occur after each dose of nicotinic acid, and it may cause vomiting, diarrhea and as well as peptic ulcer in GI tract, and dryness and hyperpigmentation in the skin. And the long-term use of nicotinic acid may cause liver dysfunction and jaundice, which may lead to serious liver damage, and it may lead to long-term use may lead to hyperglycemia, so it may precipitate the diabetic condition, and hyperuricemia and gout and atrial arrhythmia are other side effects. And this nicotinic acid is contraindicated during pregnancy as well as it is contraindicated in children also. Now coming to uses, nicotinic acid is a wide spectrum hypolipidemic agent, and this is very efficacious in case of type 3, type 4 and type 5 of hypertriglyceridemia, whether it is associated with a rising cholesterol level or not. And nicotinic acid is mostly used to lower very low density lipoprotein and rise in HDL level, and used as an adjunctive drug along with the statins as well as fibrin. And the nicotinic acid is most effective drug in reducing plasma triglyceride level and also to control the pancreatitis associated with the severe hypertriglyceridemia, mostly in genetic type of type 4 and type 5 hyperlipoproteinemic disorders. So that are the uses of nicotinic acid. Now coming to the last class of drug, that is steroid absorption inhibitors like Statins. So this is a novel drug that will act by intestinal absorption of cholesterol as well as phytosterols. That is the mechanism. They will interfere with the specific cholesterol transporter protein NPC1L1 in the intestinal mucosa, and it will reduces the absorption of both dietary as well as biliary cholesterol. That is the mechanism. Now this ezetimibe may be used for the monotherapy or combination therapy with HMG-CoA reductase inhibitors for the reduction of elevated total cholesterol. So that is all about the hypolipidemic drugs. Here we had discussed introduction about hyperlipidemia and different classes of hypolipidemic drugs, mechanism of action, adverse effect and uses of some special drugs from each classes. So hope it is clear. Thank you for watching this video.